Welcome everyone to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
Transformation Nurse Academy podcast. This is a special episode for Miss Pat because she was asking me how come I don't do medical shit anymore, and I do. I just have been caught up on this book, The Success Principles. It's really hit home for me, helps me kind of mellow me out, and I like the positive information it gives me, and I know it works because shit's been changing for us here at Central Valley Medical. So I appreciate you guys. So this week, or this special episode, we're going to talk about head injuries, right? How many of you know what head injuries are? So head injuries is called the Head Injuries, Essential Knowledge and Practical Tools for Nurses. So welcome and thank you again. We're going to be talking about head injuries, why this matters. Head injuries, you know, when someone gets a head injury, they could have a head bleed, they could have some increased ICP. It changes the way, the pressure's put on all of your cranial nerves and your spinal column and stuff like that. So it's very important, that we talk about these things. So as a nurse, especially an ER nurse, when you're talking about taking care of patients with head injuries, you want to make sure that you know what you're doing, how to monitor it, what to look for, early signs of increased ICP versus late signs of increased ICP. So that way you can maybe prevent bad shit from happening. So anyway, we're going to talk about epidural hematomas. We're going to talk about subdural hematomas, diffuse axonal injuries, herniation syndrome, and different types of skull fractures. We're not going to go great detail. I'm going to keep it light stuff. Hopefully that you will learn some stuff. Sorry, I'm trying to type and do multiple things. Let me see here. Hold on one second. Give me a second here. All right. So why does this matter? Head injuries are among the most critical conditions that healthcare providers can encounter. And so, prompt intervention can make a significant difference in patient outcomes. And here's why. There's high incidence in head injuries. They're widespread, resulting from various incidents like falls, accidents, sports injuries, assaults. They can affect anyone from young children to old people. When you got somebody that's on anticoagulants or they're drinking, they're drunk, boys, kids just jump off the damn building and shit, they can have head injuries. So the diverse causes mean that head injuries can present in many different healthcare settings, such as emergency rooms, trauma units, outpatient clinics. And it's vital that nurses and other healthcare workers recognize these dangers, right? So the problem is we get caught up with shit that we can see and not shit we can't see. So when I'm teaching, I always teach people this. It's not the shit you see that's killing your patient. It's the shit you ain't seeing. If you get hit in the damn head, you're so worried about the bruising and the bleeding that you're forgetting what's going on. So unlike visible injuries, the internal impact of head injuries might not be immediately obvious. So a patient may appear stable, alert initially, but then deteriorate quickly because of the swelling and bleeding that progresses inside the skull. So this hidden danger that makes it an essential part of your assessment skills is important to understand the early signs and symptoms of head injuries. Head injuries can lead to rapid and sometimes unpredictable declines in mental status, neurological functions, and vital signs. So this is why you got to pay attention. Intracranial bleeding or swelling can increase pressure inside the skull, compressing brain structures and impairing the brain function. So if I took my hair and my scalp, my skin, and I pulled it off and I set it down on the table, you would see the top of my skull. And then if I took my skull and removed my skull cap off, and you look down inside my head, you'd see my brain. Then if I pull my brain out with my brain stem attached and set it onto the table, Down at the bottom of an empty skull shell, you would see the foramen magnum. I know I'm probably not saying that right, so Anna, don't get my balls busted, but it's the little hole at the bottom of your damn skull. That's where your your cord comes up, and your spinal cord, your brain stem, and all the 12 nerves go down and meet together and attach. So now put all that shit back together. Put your put your brain back in there, and put your skull cap back on, put your hair and your skin back on. Now, if you hit somebody in the head, your brain starts to swell. It only has one way to go, and it tries to push downward or maybe out through your eyeballs, your nose, and your ears. But all that pressure is pushing down on those cranial nerves, and that's what you're going to see when you're assessing your patient. So when you assess your patient, you're thinking about the early signs and symptoms. So without timely intervention, that increased cranial pressure can reduce blood flow to the brain, which is called cerebral perfusion, and that can lead to brain ischemia and permanent brain damage or even death. But if you're not aware of these signs and symptoms and you don't know how to pay attention to it, that's your fault. You have to take 100% responsibility in your assessment skills and understanding these types of head injuries and what the signs and symptoms are, so that way your patient doesn't have a bad outcome. So if you do get brain ischemia, the brain is incredibly sensitive to oxygen deprivation. Now, we always talk about oxygen, but remember, your brain needs glucose too. So don't forget glucose, but your brain is sensitive to oxygen deprivation. If blood flow to the brain is interrupted or reduced, cells start to die within minutes, leading to irreversible brain damage. So the thing that you have to think about, though, is not only does the brain need oxygen, but it also needs glucose, it needs nutrients, right? So these are the things that you want to pay attention to. And tests that you can do, electrolyte, CMPs, your complete metabolic panel, your glucose levels, things like that, your ABG, your CO2 levels. So don't forget all these things. Don't just get fixated on oxygen. Does that make sense? So the lack of nutrients is also important. Uh, Rapid cell death. Brain cells are particularly sensitive, so they die within a few minutes from reduced blood flow. But besides oxygen, the interruption of blood flow also deprives the brain of essential nutrients like glucose, which are necessary for the proper I can't even say it, neuronal, Neuronal. How the fuck you say that, Miss Pat? Neuronal. Neuronal activity. How's that, Anna? Um, Severity depends on the duration. The extent of the brain damage is directly related to the duration of oxygen deprivation. So we're going to talk about these things, as we go on. Maintaining adequate cerebral perfusion, or CPP, is essential to ensure that the brain receives oxygen and the nutrients it needs. So what I did was, and I don't know, people can come out and test if you want. If you go to morethancpr.com, morethancpr.com, morethancpr.com /head injuries, I created a thing called a CPP calculation based upon the Monroe-Kelly Doctrine. Monroe, Monroe Kelly, Kellie Doctrine. If you've never heard of the Monroe-Kelly Doctrine, the Monroe-Kelly Doctrine it explains how the brain and the blood and the cerebral spinal fluid maintain a constant volume within the skull to maintain a normal ICP. The Monroe-Kelly Doctrine states that the total volume of the brain, blood, and CSF is constant, and that any increase in one component must be compensated by a decrease in the other. This is because the skull is a rigid container of fixed volume. So the importance of the Monroe-Kelly Doctrine is that because a raised ICP can be life-threatening, and after a brain injury, the ICP can increase due to bleeding, edema, which can impair brain function and lead to death. So the doctrine explains how the body redirects blood and CSF outside the cranium to create space and reduce the ICP. So the Monroe-Kelly Doctrine was established by Alexander Monroe Secundus in 1783, who observed that the brain is nearly incompressible and that the skull is rigid. So that's a long time ago, huh? So you got to think about it. If you don't know what the Monroe-Kelly Doctrine is, I encourage you to look it up. I encourage you to read it. There's a lot of places that you can go to. right? So the Monroe-Kelly Doctrine, like I said, was first described over 200 years ago by Dr. Alexander Monroe and Dr. George Kelly. It describes the direct relationship between the contents of the cranium and the intracranial pressure. So according to the Monroe-Kelly Doctrine, the contents of the cranium, which are brain parenchyma, blood, and CSF, are constant and fixed. In adults, the intracranial compartment is protected by the skull, a rigid structure with a fixed internal volume of 1,400 to 1,700 milliliters. The brain parenchyma makes up 80% of that volume. The CSF makes up about 10%, and blood makes up the other 10%. So, according to the doctrine, any increase in the volume of one component necessitates a decrease of the other components. In other words, if the parenchyma goes up 90%, then the CSF probably goes down to 5 and the blood goes down to 5. I guess it just depends on what's going on. We're going to talk about the normal values. So there's three components to the Monroe-Kelly Doctrine. CPP stands for cerebral perfusion pressure. Then you have the ICP, or the intracranial pressure, and then the MAP, or the mean arterial pressure. The CPP, the normal CPP, is about 60 to 80, right? And then the MAP is normal is about 50 to 150, and the ICP is 0 to 10. So the Monroe-Kelly Doctrine is CPP equals MAP minus ICP. So if you go over to my tool that I created, I talk about that. CPP is the pressure required to ensure adequate blood flow to the brain. Calculating the CPP helps assess the risk of brain ischemia and brain herniation. So CPP, again, equals MAP minus ICP. So low CPP can lead to brain ischemia, while high ICP can indicate severe brain injury. And so I give all the normal values on the tool I created, step-by-step tool that walks you through. If you put in your blood pressure, like I'm over here on the tool, and I know you can't see it, but I'm putting in the blood pressure 130 over 70. It automatically calculated for me a map of 90. And then you put in the ICP. Let's say the ICP is 10. And then you hit calculate CPP. And then it's going to tell you MAP is 90, which is within normal range. CPP is 80, which isn't with normal range. So cerebral perfusion is adequate, no immediate intervention needed, but monitor the ICP, maintain head elevation at 30 degrees if needed to promote venous drainage. And then on here, I wrote, I had it right. Signs of increased ICP, early signs are headache, nausea, vomiting, confusion, agitation. Late signs are asymmetric pupillary dilatation or asymmetric pupillary reactivity, coma, abnormal posturing. And then we're going to talk about Cushing's response, which is the three signs of Cushing's response is reflex bradycardia, widening pulse pressure, and decreased respiratory effort. So remember what I said, if you get hit in the head and you got the increased swelling, it's pushing down on those cranial nerves in your spinal cord. Those spinal nerves are the ones that help with your breathing. Your hypothalamus controls breathing, temperature, heart rate. So you're seeing these things because it's compressing on these nerves, which control all of this. And so you're going to see it in your patient. So long-term consequences, for patients, survivors of head injury may face long-term complications, including memory loss, motor impairments, cognitive challenges, emotional changes. Severe head trauma can significantly impact a person's quality of life, can impact their relationships, their ability to work, or even engage in daily activities. Can't even do their damn ADLs. So early recognition and intervention can sometimes prevent these long-lasting effects, making it impossible for the patient to recover with fewer residual impairments. So what are the legal and ethical responsibilities? So as a healthcare provider, you had a responsibility to deliver timely care and competent care. If you ever watch him, his name's Dr. Randy Nurse or Dr. Nurse Randy. I know, don't be mad at me, Dr. Randy. Dr. Nurse Randy, I think that's his title on TikTok and Instagram. I've been posting them. He talks about this. You can't blame the hospital. You are responsible for your nursing practice. Own it 100%. You're responsible. If you're taking care of patients and you don't have the knowledge or the competency, then you should have said no. So you can't blame the hospital and your charge nurse. You have to be responsible for the care you provide, whether you know what to do or not. So missing signs of head trauma can delay treatment, and these delays in these interventions can have legal consequences for you and for the providers and the facilities. So by being vigilant, using tools, using these knowledge that you provide, go to classes and learn, these things will help you provide timely care for your patient. So you can't complain about these things if you don't know what to do. All right. So let's talk about these different types of head injuries. So, we talked about epidural hematomas, subdural hematomas, diffuse axonal injuries, herniation syndrome, and different kind of skull fractures. So let's talk about epidural hematoma. So the epidural hematoma is a collection of blood that forms between the skull and the dura mater, the outermost protective membrane covering your brains. This is usually caused by a arterial bleed, and it's usually related to the middle meningeal arteries, right? And so this is a cause that the artery gets torn from the skull, and you start to bleed inside the brain. So an epidural hematoma is a collection of blood between the skull and the dura mater. That's the thick membrane that covers your brain. Your brain has three membrane layers. It's got the meninges, which is the layer between your bony skull and your brain. The purpose of the meninges is to cover your brain and protect your spinal cord. And then the dura mater is the outermost uh, part of your meninges, right? So an epidural hematoma can be life-threatening. It usually requires immediate treatment. It can cause brain damage, possibly death if it left untreated, right? So who's at risk? Although anyone with a head injury can be at risk for epidural hematomas, they're most commonly seen in young people, because young people like to do what? Snowboarding, skateboarding, jumping off fucking bicycles, car accidents. Um, Epidural hematomas are 4 times more likely to occur. I wonder in men versus women, because men are crazy and shit. And it's usually rare to, after 60 and stuff, but it can happen. Epidural hematomas make up about 10% of people with head injuries. 75% of people with epidural hematomas, usually from the, like I said, from the temporal area or the middle meningeal artery. Signs and symptoms: you're going to have severe headache, nausea, vomiting. You'll have enlarged pupils, confusion, slurred speech, weakness on one side of the body. This person with the epidural hematoma, they may experience a brief loss of consciousness after this head trauma. Then they're going to be followed by periods of alertness or lucidness, and it may last for several hours before they become unconscious again, and then ultimately go into a coma. So you got to think about this. If left untreated, though, they can have seizures, breathing problems, loss of brain function, coma, and death. So again, what are the causes? You can develop a epidural hematoma from trauma, but you can also get it from infections, anticoagulants, hemorrhagic tumors, things like that. So that's the epidural. So what is the treatment? Epidural hematoma is usually a medical emergency. Um, in the presence of a severe headache, decreased brain functions, you got to have a craniotomy. They're going to remove the skull and the cap and just try to remove the clot, try to leave it open, maybe, a flap so they can let the brain swell without causing pressure on the spinal cord or the brain stem. If you have a spinal epidural, you may have to have a laminectomy. All right. So these are things that you may have to think about. You may have to use medications. We'll talk about all these medications later, but there's certain medications that we kind of use with head injuries to try to decrease the increased cranial pressure. All right, the next one is the subdural hematoma. The subdural hematoma is caused by a collection of blood that forms in between the brain and the skull, usually caused by a head injury, but it's usually related to old people, geriatrics, alcoholics, people on anticoagulants. It's caused by the tearing of the bridging vein that runs between the brain surface and the dura, usually due to some kind of head injury like a fall. It's a blood clot that forms between the brain's protective layers, the meninges. It's more common in older adults. Like I said, it can be associated with long-term heavy alcoholics, use of certain medications, people on anticoagulants. Signs and symptoms: you're going to have headache, nausea, vomiting, confusion. You could have loss of consciousness, personality changes, vision loss. A small subdural hematoma may resolve on its own, but a large one can lead to herniation because it's increasing that pressure. So again, subdural hematomas You're gonna have you can so there's different the dura matter is one of the meninges. You have the dura matter, the arachnoid matter, and the pia matter. There's different types of subdural hematomas. You know how fast you have acute, subacute, chronic. Some of the signs and symptoms, like we talked about: headache, nausea, vomit, slurred speech, balance, muscle memories. You can have paralysis. You can have seizures. Again, you fall and hit your head. Old people fall and hit their head all the time. You're riding in a car. You're riding a bike. Different cause. Risk factors: people over 65 and babies are more risk for subdural hematomas. So as you age, your brain shrinks inside your skull. The space between your skull and the brain widens. This makes the tiny veins in the membranes between your skull and brain stretch. So probably why alcoholics is it dehydrates your ass. I guess I gotta stop drinking, Miss Pat, so I don't get a subdural hematoma. Playing contact sports, again, blood thinners, things that you can use. You know, a CT scan, MRI is what we use to diagnose these things. You may have to have a craniotomy. You know, a neurosurgeon temporarily removes the section of the brain or the skull and then removes the hematoma, you know, close out. You can do a burr hole. That's where a neurosurgeon drills a small hole in your head and kind of lets the blood leak out. The patients, whether it's a subdural, epidural hematoma or any kind of head injury, they may need you guys call it the EVD now, external ventriculostomy device. We just used to call it a ventriculostomy device. It's like a little catheter drain that goes like almost like looks like a folded catheter. It goes into your ventricles of the brain. It drains out into like this long ass folded bag that looks like a Volutro or something. But it can drain CSF, it can drain blood, it can help manage your ICP. So recovering from a subdural hematoma depends, you know, depends on how severe it is, right? Depends on what's being caused. The next one we're going to talk about is diffuse axonal injury. So, all right. So, what is a diffuse axonal injury? So, a diffuse axonal injury, it's not a good thing, but a diffuse axonal injury is a type of traumatic brain injury. It's called a DAI, type of traumatic brain injury that results from blunt injury to the brain. In the United States, the traumatic brain injury is a leading cause of death and disability among children and young adults. So, DAI, like I said, is a type of traumatic brain injury that results from some type of, you know, whether you're falling, whether you hit your head, a car accident. We look at your Glasgow Coma Scale. You know, the normal Glasgow Coma Scale is the normal is 15. But we talk about traumatic brain injury, we give them ranges. Um, let's see, I can't remember what it is. Let me see. Let me look at my fucking book. Now I forgot. Now I'm having a brain fucking fart. Let me see here. I gotta look this shit up. Bear with me, motherfuckers. Try to memorize all this shit in your head. So the classifications are mild, moderate, and severe. A Glasgow Coma Scale of 13 to 15 is mild, moderate is 9 to 12, and severe is 3 to 8. All right. So the etiology involve high-speed motor accidents. Most often, is common, involves accelerating and deceleration, a motion that leads to shearing, and it forces the white matter of the brain to shear off. This leads to microscopic and gross damage to the axons in the brain at the junction of the gray and white matter. Diffuse axonal injuries are it commonly affects the white matter tracts, which involves the corpus callosum and the brainstem. So these are the things. So etiology, the epidemiology, I can't even say the big ass word. The true incidence of the DAIs is unknown. However, it's estimated that roughly 10% of all patients with TBIs admitted to the hospital will have some kind of degree of DAI. So, you know, what are you going to do with DAI? I mean, what can you do with that? So, like I said, it's the shearing of the nerves, the axons. We call it a closed brain injuries, right? It could be a penetrating brain injury. Primary brain injury refers to the sudden and profound injury to the brain that is considered more or less complete at the time of the impact. Secondary brain injury refers to the changes that evolve over a period of hours to days It includes an entire series or steps or stages of cellular, chemical, tissue, or blood vessel changes in the brain that contribute to the further destruction of brain tissue. So you can have comas, you can have confusion, you can have short attention spans, memory problems, amnesia. You can have problems with judgment, the inability to understand abstract concepts. You can have motor deficits such as paralysis or weakness, spasticity, which means tightening and shortening of the muscles. You can have poor balance, decreased endurance, tremors, swallowing problems. You can have perceptual or sensory deficits like changes in hearing, vision, and taste. You can lose sensation of your body parts. You can have difficulty understanding where your limbs are in relationship to your body. You can have communication and language deficits like aphasia, difficulty speaking and understanding speech, difficulty choosing the right words, slow and hesitant speech. You could have functional deficits like you can't give yourself a bath, you can't do your ADLs. Social difficulties, impaired social capacity resulting in difficult interpersonal relationships, meaning you got a low affect. You can have regulatory disturbances. You could be tired, dizzy. You could lose your bowel and bladder, right? You could be apathetic. So, can these brain injuries heal? Most studies suggest that once the brain cells are destroyed or damaged, for the most part, they cannot regenerate. However, recovery after brain injury can take place, especially in younger people. In some cases, the brain makes up for the injured tissues. They're finding out that they can create new pathways and grow new pathways elsewhere. So just think about what you're going to do with these types of patients and how we could help them and stuff. All right. Herniation syndrome is another injury. Herniation syndromes are a group of conditions that occur when the brain tissue is displaced from its normal location in the skull. So, brain herniation is a life threatening medical emergency that occurs when pressure inside the skull increases, forcing the brain tissue to move through openings in the brain's tissue sheets. These symptoms include dilated pupils, loss of brain stem reflexes, respiratory arrest, abnormal breathing, abnormal muscle contractions, eye problems. They're broken into what's called subfalcine herniation or transtentorial herniation. Subfalcine herniation is the most common type of intracranial herniation where the brain tissue is displaced underneath the false cerebri. The transtentorial herniation is the movement of brain tissue from one intracranial compartment to the other, and this can be uncal, central, or upward herniation. Brain herniation that can be caused by a number of things, such as brain swelling, head injury, stroke, brain tumors. It could be a collection of pus and other material that's, caused by bacteria or fungus, some kind of abscess. It can be caused by disorders such as liver or kidneys. So there's a lot of different things that could cause these brain injuries, these uncal herniations and stuff. All right. Skull fractures. There's different types of skull fractures. More specifically, we're talking about Lefort fractures. There's Lefort fractures. There's zygomatic maxillary fractures. There's nasal orbital ethmoid fractures. You'll see swelling around it. Now, Lefort fractures, they are named after the French surgeon René Lefort, who studied how blunt force trauma affected cadaver skulls. So he broke them down into three classifications. You got Lefort 1, Lefort 2, Lefort 3. Lefort 1 is usually where your maxilla, your mouth, you talk back to your mama, so your mama smacked your mouth. Lefort 2 is your maxilla and right underneath your cheekbones and around your jaw. You didn't learn your lesson, so now your mama punch you in the nose and the mouth. Lefort 3 is more across your your zygomatic up here at the top around your eyes. It goes all the way down to your upper maxilla right here and stuff. I'll have Jane put some pictures and stuff so you can see it. But most of them, you're going to see swelling around the eyes. They call that periorbital ecchymosis. Bruising around the eyes, periorbital ecchymosis. You can get bruising behind the ears or mastoid ecchymosis. You could get runny nose, ear drainage, eye drainage. Runny nose, you call that rhinorrhea. Ear drainage, you call that otorrhea. You could get lengthening and flattening of the face. There's different types of problems. And so you're going to get airway issues because if those bones in your face and eyes and mouth are broken, those shards can go down into your upper airway and block your lower airway, and you can have airway issues. So let's talk about what can happen to your brain. So when your brain swells, it's going to change your cerebral peripheral perfusion. And your patient may suffer from what's called Cushing's response or Cushing's reflex. Is a physiological reaction to increased intracranial pressure. It's characterized by a triad of signs called the Cushing's triad, which is known as widening pulse pressure, reflex bradycardia, and decreased respiratory effort. So Cushing's reflex or Cushing's triad is a compensate. I can't even talk today. Cushing's reflex is a compensatory mechanism that helps maintain cerebral perfusion and adequate perfusion of vital brain centers. So in severe cases such as your intracranial hemorrhage or these types of tumors, traumatic brain injuries, Cushing's reflex is kind of things that your body's trying to do to compensate. So the Cushing's reflex or the triad was proposed in 1901 by Dr. Harvey Cushing. He believed that the dramatic increase in blood pressure was a reflex to the brainstem ischemia seen in patients with increasing ICP. This ICP is caused by the different brain injuries, but a mass effect from a tumor or whatever kind of things. In most cases, the increased ICP, the CPP would drop as the systolic blood pressure dropped as well. So intracranial pressure and cerebral blood flow are determined by the amount of blood and CSF in the skull and the force exerted by the brain on the inside of the skull. An autoregulatory mechanism enables the CSF movement between the brain and the spinal cord or the spinal sarcnoid space and constriction and dilation of the arterioles to maintain ICP with a normal limit. So the Cushing's reflex is a physiological nervous system response to acute elevations of ICP, resulting in a Cushing's triad of widening pulse pressure, meaning you're increasing systolic and you're decreasing diastolic. Your heart rate goes down, or bradycardia, and you have irregular respirations. Because if you're breathing too fast, you're blowing off the CO2, or if you're bagging a patient too fast, you're blowing off the CO2, and your blood vessels in your brain constrict, which will drop your ICP, but it also drops your perfusion to your brain. So the Cushing response, in the first stage of Cushing's response, your blood pressure and your heart rate rise in response to the sympathetic activation to overcome the increases of the ICP. This sympathetic response allows for the brain perfusion as long as the ICP is not too high to overcome. So for the brain to remain adequately perfused, the mean arterial pressure or your MAP must be maintained higher than your ICP. In the second stage of Cushing's response, hypertension continues to be present, but the patient becomes more bradycardic rather than tachycardic. There are different opinions on the mechanisms leading to the stage, but they think that the blood pressure leads to the activation of the baroreceptors in the aortic arch, triggering the parasympathetic activation and resulting in the bradycardia. But again, there's different theories behind that, and still not wholly agreed upon why bradycardia happens. But the blood pressure will continue to rise until the MAP overcomes the ICP and blood can adequately perfuse the brain, therefore resolving hypoxia and avoiding infarction. This activity occurs due to the compression of the brainstem by the increased ICP. And as a result, it's affecting your breathing. You get these kind of agonal breathing, or some patients breathe really, really fast. Some patients breathe really, really slow. Like you'll see it, like when you see it, like, holy crap. So, Cushing's response is pretty damn crazy when you see it and stuff. So again, Cushing's response is you have an increased ICP. This, like I said, this can result from from the bleeding of the brain or your head injury or whatever. It activates the sympathetic nervous system. Then the parasympathetic nervous system activates Again, your heart rate decreases, you have these irregular respirations, your widening pulse pressure, your blood pressure changes. Treatments, though, that you can provide for any of these type of head injuries. You can give intravenous mannitol, which is an osmotic diuretic. Even though it's not really, they don't like to do this anymore. You can provide hyperventilation temporarily if you need to. Hyperventilation will, like I said, will help blow off CO2, which will help decrease your blood flow to the brain, which will, temporarily decrease your ICP. But again, you're not getting blood flow and nutrients to the brain, so it can really fuck your patient up. Elevation of the bed, you want to go about 30 degrees. You don't want to go too high. You don't want to go too low. But again, there's some controversy about these things now. You may want to give hypertonic solutions. 3% saline, 7% saline, 23% saline, or hypertonic solutions that can help change the osmotic pressure and shift fluids around in your skull and your brain. You can put in an external ventricular device where you can drain the extra fluid out to help decrease the ICP, give your brain room to, to decrease its swelling. And then, you can do a craniotomy. These are things that you could try for this Cushing triad. So Cushing's triad is indicative of a medical emergency and medical attention is required. The treatment is aimed at decreasing the ICP as well as reversing the cause of the increased ICP, which is probably the head injury. Like I said, mannitol is an osmotic diuretic. It's often provided intravenously. It can be highly effective in lowering your ICP and increasing the cerebral perfusion pressure. Other medications you may want to think about is diuretics like furosemide or steroids, sedatives, propofol, which will help kind of decrease, the patient from breathing too fast or being overstimulated. Hyperventilation, like I say, you're breathing fast for the patient. I'm not a big fan of it, but you can use it. Reverse Trendelenburg is sometimes used. It's also, it's recommended sometimes to help decrease the ICP. Like I said, in some cases, you may want a drain in there to drain out the extra CSF fluid. And then again, in cases, you may want to do a craniotomy. So the most important thing I want you to remember, Cushing's triad consisting of bradycardia, reflex, bradycardia, decreased respiratory effort and widening pulse pressure. Again, it's the body's response to increased intracranial pressure. It usually indicates a severe lack of oxygen and nutrients to the brain tissue. And it's your body's way of trying to deal with this, brain injury or whatever the problem is that you're having and stuff. So again, if you want to know more about this, don't be afraid to read and study. Take some time to learn about this, learn about your Cushing's response, learn about the Monroe-Kellie Doctrine, learn about the early and late stages of increased ICP, such as headache, nausea, vomiting, pupil dilatation, things like that. All right, so using these tools can help build your confidence. I want to encourage you to use these tools that I help, that are created for you. Practice scenarios and stuff. I have activity cards. If you want to look at them, you can look at them as well. You can check our TNCC class. I teach the trauma nurse core course. So these are things that you can do to help improve your skills. All right. So I hope you learned a lot. Remember, why does it matter? Because head injuries are a really critical condition that you want to make sure that your patients have a better outcome. So again, I hope that you learned a lot with this episode. I hope Miss Pat's happy that I did a damn episode on medicine again. I really appreciate you guys. You have a great night, and thank you for joining us again here at the Transformation Nurse Academy. All right, bitches, I love you. Let me know what you think. Visit us at transformationnurseacademy.com. Visit us at the morethancpr.com. And don't forget, we're always here for you. I love you, bitches. Peace out, mothers. Say bye, Miss Pat.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.